And we're live in 5,
4,
3,
2, 1.
Hello, everybody. I want to welcome you to our 2024 Arthroplasty Triumphs and Defeats. And we're going to have an exciting hour to talk to you this evening. We have Harvey Smith from the University of Pennsylvania talk about some really groundbreaking research that he's done. And I'm going to give a little introductory talk about lumbar disc replacement as an intro to what he's going to talk about. So I am going to share my screen here. And so it's interesting that it's now been 24 years of disc replacement in the US. And the thought for this was really, what do we have to look forward next? Is this as good as we need to get, or is there something in the future? But I'm a firm believer in technology and science, so there really is something next. But what I'd like to do is just talk about where we came from. And little did I realize when Karen Buettner-Johns, who was one of the co-founders of the SB Charité disc, which was the very first one that was approved for use in the US, and the first one that was done at TBI in March of 2000, that we would now be celebrating 24 years of lumbar disc replacement. Little did Dr. Blumenthal, Dr. Ziegler, and myself imagine that here we are almost a quarter of a century later doing disc replacements. Since that time, as a group as a whole, and the three of us have done the majority, we've done over 5,000 artificial discs. So why not lumbar TDR? For example, in 2024, you would never offer the patient whose x-rays are on the right a hip fusion. You would offer them an artificial hip joint. And we see this in all areas of healthcare. We see restoration of natural function from hips, knees, shoulders, ankles, and to the dental implants. And we owe a lot to the dental research with porous ingrowth into the implants and other designs as well. But why has there been resistance restoring spinal motion utilizing disc replacement? And which would you rather have? Would you rather have the fusion on the right, or would you rather have the nice motion we see on the left side? And we know that motion is better, and it's a natural solution. And it may prevent these pictures down here that we see all too often in our peer review meetings, where a patient has a single level fusion, progresses to a 2-level fusion, maybe a spinal cord stimulator, and then is a T10 down to the pelvis, and then eventually is the T4 down the pelvis, and before you know it, they have an entire metal spine. And we also know that in many cases, a disc replacement can restore sagittal alignment by allowing the patient to find their natural balance. And we owe this concept really to Terry Marnay, who was the inventor of the ProDisc. And also, this particular patient who had a previous fusion at the L3-4 level and then had changes at the level above and below, he was offered to have a fusion extending from now L2 down to L5. What would be in his future? He's only 52. And you can see that he had stenosis at both levels, although this was at the L2-3 level. And we reconstructed him with a 2-level fusion, 2-level artificial disc to prevent him from having an additional 2-level fusion. So currently, there have been 10 USA IDE studies comparing TDR to fusion, and the most recent ones comparing disc to disc, which is level 1 data showing that degenerative disc disease can be treated effectively. And this is good data. We see all the discs that are listed there. The ones in yellow are the ones currently approved that we are using. We have the ProDisc L, the ActiveL, and then the 2-level ProDisc L. And I listed at the bottom the Modus or 3-spine, or it's also called Balance Back. That trial began in 2022, and we'll say more about that later. And the literature about lumbar disc replacement has just skyrocketed, and we can see here from the early 2000s to the present, there's been over 800 articles published. And that's a lot of evidence. So I don't want to talk about a lot of literature, but I just want to concentrate on 3 long-term papers. And one is our friend Terry Marnay, who published on the 7 to 20-year outcomes of almost 1,200 patients with 1 and 2 level disc replacements. And the most important thing, not only did the patients have statistically significant improvement of their ODIs, which was maintained, but the rate of revision was less than 1%, that is 0.7%. So this is up to a 21-year follow-up. And adjacent level surgery was at 1.85%. And I doubt that there's any fusion papers that could show nearly as good of results. Now, this other paper, although it's not purely a disc replacement paper, it's a hybrid that Matthew Scott Young, another one of our friends, from Australia, showing a long-term follow-up of 617 patients with the baseline follow-up up to 96 months. And although this didn't include all the outcome data that we normally publish, it showed that these patients did well. And this was a combination of a fusion, usually at L5S1, and a disc replacement at the level above. And the next long-term series that we did, which is about to be published in Spine, was our 20-year experience with over 2,000 patients, with the mean follow-up about 80 months. And we had 27 removals or revisions. And this is the only thing we looked at. We didn't look at anything else. We didn't look at adjacent segment disease because this was very early on as we went through our patient data. And our revision rate was 1.26%. Now, Terry Marnay smiled when I gave this, and he was there, but 40% or 41% of the removals and revisions occurred within the first 25 cases that myself, Jack Ziegler, and Scott Blumenthal did. So if you take them out, we really have less than 1%. Another interesting finding from this data was that there were 264 patients that had a minimum of 15-year follow-up, and there was only 1 revision. And that was because the patient was in a severe car accident and had a fracture above the level of the disc replacement. So what have we learned? Well, much like cervical disc replacement, we've expanded the indications. For example, early on, we would hear that, well, I can't find a patient that's a candidate because they had degenerative facet changes. If you read what the radiologist says, every patient, I will guarantee that you get an MRI scan, they will say there's facet arthropathy, there's degenerative changes. And in reality, 1 is normal, grade 2 may be a little bit of narrowing, grade 3 is further narrowing and maybe a little bit of cupping, but there's tremendous variation. Grade 4, obviously severely degenerative, that you could see with the high-grade degenerative spondy. So these patients are really not contraindicated to having a disc replacement. The other thing that we've learned is that a completely narrow disc can occur in the face of having normal or even grade 2 facet changes. And these discs too can be mobilized and restored with a lumbar disc replacement very effectively and successfully. So the fact that a patient is excluded because of degenerative disease and a very narrow disc is no longer the case. Now, the other thing that we've learned, and I've learned this from Terry Marnay, is that a patient can have a stable degenerative spondy with a couple millimeters of listhesis with normal joints. They too can be treated with the TDR. Although we are not aggressive as they are in Europe and some other place in the US, we will treat 3-level disease and occasionally even 4-level. But again, these patients do very well. And I asked Terry Marnay, I said, Terry, why do patients with 3 or more level disease do so well compared to the single levels? He said, Rick, these patients are hurting from more than 1 level, and you take the pain generator away, and these patients are very, very grateful. So I will say that if you pick your patients properly, a 3-level patient is a very, very grateful patient. Now, the other thing that we've learned is that the TDR has proven to be more durable than total hips and total knees. And if you look at our revision rates and Terry Marnay's revision rates, remember mine or ours includes our learning curve. So it's really less than 1%. And so is Terry's, less than 1%. Whereas if you had a total hip replacement done by one of the mavens, they would tell you that you have a little bit more than 4% chance of needing to be revised in 10 years and 15% at 20 years, not 1% like we're talking about. And knee replacement is perhaps a little bit better. So today, lumbar TDR are really my most gratifying operations. And these are just a couple pictures. This was a 35-year-old ski patrol female that we did a 3-level on, and she's back doing her thing. The middle is a 43-year-old with the 2-level acting crazy. And then this 53-year-old CEO with the 3-level lumbar TDR about 6 weeks after surgery in Iceland, hiking around. Not that I recommended that. So where are we now? Well, we have more than 30 years experience and slightly fewer years than cervical TDR. The literature search for lumbar disc and cervical disc, and before I said it was 800 lumbar, but if you add the two together, it's greater than 2,000 articles. Many consider the cervical disc to be the new gold standard, and Scott Blumenthal talked about this at the last arthroplasty. But to reiterate, the TDR has been studied more extensively than no other area in spine, and by so many FDA trials and meta-analyses. So there's a continuing growing body of evidence from the FDA trials, prospective trials, retrospective studies across the US and from other countries. And we continue to see research supporting the long-term safety, the maintenance of good outcomes that are achieved early post-op by 6 months and are maintained long-term. And also that the TDR allows range of motion long-term, reducing adjacent segment disease. But one of the real issues for TDR is its adoption, and much of it, unfortunately, comes down to dollars on many fronts, from the device companies, where it's a minor portion of their income, from the insurance carriers, where they don't want to pay for it, and the surgeons, because we don't get reimbursed a whole lot of money. And overcoming the remaining barriers will not come from more literature. The data is there. But it will take the surgeons and their spine societies, along with the spine companies, to make a commitment to motion preservation and to help us increase the reimbursement to equitable levels. But for now, I believe the greatest driver that we are seeing are patients are demanding lumbar disc surgery over fusion. But let's look at a few things that are in the horizon. So the 3-spiner Modus, which is a 2-segmented disc replacement, in which it really requires removing of the posterior element, has finished its FDA trial, and they published a preliminary result. But right now, they have accomplished 150 of their disc replacement, which they call 3-spine now, against the TLIF patients. And they have complete enrollment, and now will seek out the FDA time when they can finally present it for approval. Now, we do have alternatives for degenerative disc disease. The Intercept procedure, probably not many of us do it, but Relievant sold this company to Boston Scientific for $1.3 billion, which is far greater than all of our artificial discs, cervical and lumbar together. Nucleus replacement is something that's regaining some resurgence, and there were many, many patients that were enrolled in various studies. This is just a preliminary about that. But the question is this good enough? And are our mechanical discs we use today, which we get very, very good results, is that all we need? And what's next? And these are just a couple little quotes, and Dr. Smith will get a kick out of one of them. And the first one is from Helen Keller. And she says, "He who is content with what has been is an obstacle in the path of progress." And then this is from a cardiovascular surgeon, Horace McFall, when I was a med student. He said, "Penn is a wonderful institution with 200 years of tradition, unmarred by progress." And this is really my favorite one from a friend of mine who's professor at the Harvard School of Business. And we were talking about AI, and what he tells his students, he said, "Remember that the artificial intelligence you use today is the worst AI you will ever use." So is it good enough? Well, not at all. I mean, there has to be something beyond these artificial discs, and we have biologic solutions. And that's why I asked Harvey Smith from Penn to present his groundbreaking research on regeneration of the disc, really harnessing the power of the human body to heal itself. So, Harvey, I hope I didn't take up too much time, but I'm going to hand it over to you, and I'm going to stop my share, and you can start.
Thank you very much, sir. It's a tremendous honor to be invited to participate. I'd like to thank the Seattle Science Foundation. And let me get my slides up. Are you able to see everything?
Yes, we can.
Okay, perfect. So thank you very much, Dr. Geyer, for the tremendous introduction, and really recognize you and your colleagues for really advancing the science of disc arthroplasty and for teaching us all so much. I'm going to speak a little bit over the next 25 minutes or so about some work that myself and my colleagues have been doing at Penn, looking at ways, some alternatives to biologic solutions for disc degeneration. Some of these slides I'll go through quickly just because we have to, I'm compulsive when I present all the data, but I'm going to skip over the stuff we don't have time to get too far into the weeds regarding. And let me see if I can. There we go. So I have some disclosures. I have some federal grant funding. At Penn, we also cover the VA, and I have grant funding through the VA. So I'm technically, well, I am a part-time federal employee. None of my comments are endorsed by the government. I'm the chair of the FDA's orthopedic advisory panel for devices and implants, and my comments are reflected in that role. And I'm also a committee member with the North American Spine Society. So degenerative disc disease, we all talk about it, but if we look at back this classic paper from Dr. Bowden in the 90s, we all have disc degeneration. And if you look on the cohort on the right, once you're over 60, 93% of people have degenerated discs. I'm aging. I'm in the middle cohort. 59% of people my age have degenerative findings on an MRI. And these are MRIs in asymptomatic individuals. So we need to remember that degenerative changes are part of aging. Just like our hair turns gray, we age on the inside. It can't be stopped. So degeneration in and of itself may not be pathologic. And this is something we're still struggling to understand the nuances of what is a pain generator. Right now, this is still pretty much the state of the art. Nocimed and some other companies are trying to advance this on the clinical paradigm, but right now we have the Furman grading. So we look at T2 changes on T2 weighted MRIs, grade 1 through grade 5, and as the disc desiccates and collapses, it gets an advanced Furman grade. But if we look at X-rays compared to the MRI findings, if you look on the right, by the time you start to get really significant Furman changes on the MRI, you're already starting to get osteophyte formation and disc collapse. And this is a challenge because if we have purported therapeutic to intervene, it's intuitively desirable to intervene early in the disease process. And so we're still struggling to try to understand early findings for degeneration and to identify which discs do we need to intervene on. And also, if you have a therapeutic, how do we track it longitudinally in a non-invasive manner? And I was fortunate to work with some folks. I'm going to acknowledge at the end of the talk, when I was a medical student, I literally wandered into a Center for NMR Research at Penn State, my first year in med school, and said, I'm looking for a summer research job. And they took me under their wings. And so I was involved with some NMR, MRI research with cartilage looking at T2 mapping. And we don't have time to get into the details of T2 mapping, except just what's important to note as we take this forward is that clinically we see T2 weighted MRIs, but T2 is a time constant that can be measured. It's spin, decay. And you can measure this constant, and it has findings which we showed in cartilage are very sensitive to degenerative changes of cartilage and proteoglycans, and is a surrogate for water content and glycosaminoglycan content. And so the hypothesis I had about 15 years ago or so was maybe we can apply T2 mapping to the intervertebral disc to both better quantify degenerative changes and use it as a surrogate biomarker, as you will, for our therapeutics and also to understand the pathophysiology of the disease. So Dr. Howard Ahn and Masuda, they really advanced the rabbit model for degeneration and are sort of the giants in this area. And they showed in rabbits, if you do a needle injury, you get reproducible degeneration. So we took rabbits and we injured their discs. So left is pre-injury, right is after injury. And then we performed T2 maps on them. And on the bottom, you'll see a color coordinated T2 map. And these are physical chemistry time constants that can be measured with an uncertainty. And so you see the spatial variation of the T2 properties of the disc. We can resolve the nucleus pulposus, the transitional zone of the annulus fibrosus. So at the time, a grad student working with me, John Martin, who's now an independent investigator in Chicago, he and I he did all the coding. So I would just say, I asked him what I wanted him to do, and he figured out how to do it, was how to get an automated way to T2 map these discs. And what we did was we showed in rabbits, I can look at the disc pre-injury, resolve the nucleus pulposus and annulus fibrosus. We can show the changes in the T2 values post-injury, and then do a difference map to non-invasively assess the response of the disc to an injury. And this is important because maybe not all injuries are the same. And so if you're doing a study, maybe the needle didn't go in the right way. And then if you don't have a way to quantify non-invasively the injury, then variation in the injury model may confound your assessment of the therapeutic. And so we were able to show at different levels of the disc, the population average T2 maps in the rabbit. Different discs have different properties because rabbits have more bodies than we do. But for example, the L6, L7 disc in the rabbit is below the pelvis. It's shielded by the ligaments and sees less stress. And so we showed how different discs respond to injury. And then we were able to show basically that we could get population average T2 maps in a population and then establish norms. And this is important. Like any other diagnostic measure, we can say this is for a 45-year-old person or a 2-year-old rabbit. This is the norm, and this is the deviation from the norm. And we can start to really rigorously, quantitatively assess these things. So then we said, okay, well, let's do another model. So we'll digest the disc with chymopapine. So this was an ex vivo rabbit lumbar motion segments. We digested the disc with chymopapine, different dosages, and then did our T2 mapping and T1 row mapping. And we're on the right, we see the group average T2 and T1 row maps. And then we also then took these motion segments, put them on an instrom, and looked at the biomechanics of the disc with standard stress strain curves. And unsurprisingly, what we showed was that as you digest the disc of chymopapine, it degenerates. And this is the histology of normal sham injection of saline versus increasing levels of chymopapine and the deleterious effects on the disc and the extracellular matrix. And then we show with our T2 maps, we could resolve these changes non-invasively. We don't have to do histology. You can see the control levels. And as we increase the chymopapine dosage, you can clearly see the differences in the nucleus pulposus in the transitional zone. And then this is a busy slide, but to get down to the heart of it on the right, we are able to show the significant correlations with T2 and T1 row mapping to predominantly water content, glycosamine and glycan content, and to a degree tissue anisotropy. And so we validated this non-invasive biomarker, what I call it biomarker T2, for biomechanics, histology correlation, and the content of glycosamine and glycan. And this is what really led to the next stage of our research, which I'm pretty excited to talk about. And so, as Dr. Geyer was talking about, we have a real problem with back pain. It's the #1 cause of disability. And currently, we know how the disc degenerates. And right now, on the right, unfortunately, this is still a lot of the treatment. People get fusions. If they're fortunate, they get a mechanical disc arthroplasty, but still over 400,000 fusions are done a year on the spine. And the fusion doesn't restore normal structure or normal function of the disc. And remember, the disc is effectively a shock absorber. So it's composed of a nucleus pulposus, which is a hydrated with glycosaminoglycans and proteoglycans. It's very hygroscopic. It absorbs water and it swells. And that swelling is constrained by the tension band of the annulus fibrosus. So every step that you take, you're literally walking on water. Water molecules are pushed through the nucleus pulposus, and the compressive energy is dissipated as frictional drag. And so if we wish to reconstruct a nucleus pulposus, annulus fibrosus, and a disc, it doesn't just have to look good on MRI or look good on biochemistry. It needs to function like a disc biomechanically. And so the disc is composed predominantly of chondrocyte-like cells that we call nucleus pulposus cells and fibroblast-like cells that we call annulus fibrosus cells. Annulus fibrosus are in the annulus, NP cells are in the nucleus. There's also component notochordal cells, which I'm not going to get into too much now, except remember in animal models, the notochordal cells persist for some time in some of them. In humans, generally, notochordal cells don't stay present much beyond 4 to 10 years at age at most. But we do know they secrete extracellular matrix components and MMPs and growth factors. And so they may have a role in setting the stage for the disc's biologic milieu with aging, but that still remains to be characterized. The key thing is the disc is the largest avascular tissue in the human body. And that's because of the cartilaginous end plate. And this is a slide. The cartilaginous end plate is cortical bone, hyaline cartilage. It has some chondrocytes phenotypically, but it doesn't have vascularity. And so nutrition to the disc is limited predominantly by diffusion. And so the way I imagine the disc is the MP cells are like little astronauts on the moon. It's a very inhospitable environment. It has different oxygen tension, it has different atmospheric pressures than other parts of the body, limited disc diffusion. And it's a very challenging tissue to work on if you think about it. And plastic surgeons, we're still struggling to fix wrinkles on the face. That's degeneration, degradation of collagen. And now we're going to try to do this in an incredibly inhospitable environment in terms of nutrient flow, atmospheric pressures, and those are the main ones, and lack of oxygen. And so I thought this would be a good place to stake my career and try to do something. And so right now we talked about already fusions, currently at least 400,000 per year. That number is probably going up since the papers I'm referencing. And we know reproducibly in fusions, 17 to 30% develop adjacent segment disease. And total disc replacements, now, admittedly, because my interest is tissue engineer replacement, I selectively pick some papers. As Dr. Geyer showed, they've got tremendous outcomes when the experts are doing these cases. But if you look at the literature, there are reports of some complication rates ranging from 7% to higher. Not all of them, as Dr. Geyer's series showed. In high volume centers that are well done, they have very low complication rates, but there can be complications with them, as with any surgery. But clearly, total disc replacement has a lot of, mechanically, has a lot of intuitive benefits over fusion. And Dr. Geyer shown in his literature from his group and others that it demonstrably has better outcomes than a fusion. I mean, someone with a 3-level lumbar fusion is not going to be zooming down the Swiss Alps on a ski patrol for the most part. And Dr. Hillebrand, who was one of my mentors in fellowship and residency, published a landmark paper with Dr. Bowman showing this in the cervical spine. You do a 1-level fusion, 10 years later, roughly 27% have adjacent segment disease. And that was the impetus for cervical mechanical disc arthroplasty. And so our hypothesis was, what if we could do a disc arthroplasty, but instead of a mechanical arthroplasty, put in a disc that's made of your own cells, a tissue engineered disc. The idea being that if it works like a disc biomechanically and functionally and doesn't have the wear concerns, potentially of a mechanical arthroplasty, then maybe we could advance forward with arthroplasty, standing on the shoulders of the giants like Dr. Geyer and his peers, and learning a lot about trying to prevent this cascade of repetitive fusions over and over again. And so if we're going to replace a disc, it needs to have the composition, structure, and function of the native disc. Not just look like a disc. You have to rigorously recreate a disc in all those areas that we discussed earlier. And what the group I'm working with, they had started working on this before I came to Penn, and then I think we've really carried it quite far along with our collaborators, is what we call a disc-like angle ply structure. And this is a nucleus pulposus analog that is a hyaluronic acid hydrogel that's cell-seated. And then the annulus fibrosis component is an electrospun nanofibrous PCL layer that's laid on alternating layers and cell-seated. And so that sort of creates biomechanically an analog of the disc. Later iterations, we call the EDAPs, where I'll discuss it in a bit. In order to get integration, we learned that we wanted to put a end plate analog between the disc and the remaining bone of the vertebral bodies, and that's a salt leach PCL foam end plate. And so first, and I'm going to go through this part quickly to get to the exciting stuff. First, we started in vitro, and the decision was we need to grow these discs to the size of the rat tail, the rabbit, and the goat. The reason I chose the goat cervical spine was it's somewhat upright, more so than the rodent model, and it's roughly the same dimensions, more or less, of the human cervical disc. And so we grew these discs in vitro at different time points and showed we can grow a disc. Basically, it looks like a disc biomechanically, it acts like a disc, and MRI, it's a disc. And so this is after we implanted them into athymic rat tails. So left is the native rat tail disc, and here we see 5 weeks post-implantation are DAPs, and those had trouble integrating. So then we moved to what we call the EDAPs with the end plate, where we did a partial corpectomy and dropped them in, and they integrated well, which I'll show you next. So then we did a longer term model where we did MRI, biomechanics, biochemistry, histology. These are the T2 maps. And here what you see is the native disc, the implanted disc we did at 10 weeks, and then the disc at 20 weeks. And I'm going to get back to that in a bit. But the key take home message for this part is after we implant these discs, they continue to mature on MRI, histology, biochemistry and mechanical function post-implantation. 20 weeks is 5 months. So they are living tissues that continue to grow and incorporate. And so this is the nucleus T2 of the native at 10 weeks and 20 weeks. This is the AF T2. But here's the histology. So 5 months on histology, you see the maturation compared to 10 weeks, and it's a functioning disc now. And I can show you why. This is second generation harmonic microscopy, which was really sensitive to collagen deposition. And what you see is over time, the little dotted box shows the vertebral body end plate interface. We see increased collagen deposition going from the bone into our end plate analog. So this shows functional ingrowth and integration of the disc over time in vivo. So these are living, functioning tissue constructs that continue to mature in time. And again, here, this is showing even some vascularization of the end plate analog. At 20 weeks, you see some red blood cells, some vascular channels. So these become fully integrated. And that's one of the red blood cells on the right. So then we say, does it work like a disc? Well, we put them on an instrom, and what I can show you is to the right, pre-implantation, and then you see the stress strain curves at 10 weeks and 20 weeks. These, after implantation, continue to mature in vivo and approach by 5 months, 20 weeks, the biomechanical properties of the native disc. And then on the right, we see the same thing. We tested them to failure. We literally ripped them apart. You see to failure at 10 weeks, to failure at 20 weeks. By 5 months, these are as robust as the native disc. So this brings us up to where we were around 2015. This is a nice summary slide. The center, slide A, you see our implanted disc in a rat tail. We did a partial corpectomy, and then you see the NP analog, the end plates, and this is all summary of the data I showed. And so basically, if you're a rat with disc disease, you're in good shape. We can help you. But this is the problem, is this is where literature always goes. You know, Daryl Jackson had a great quote. Here's a New York Times article. You know, in rats and mice, we cure everything. We cure cancer. We cure, Dr. Failings in Toronto's done some studies with spinal cord injuries in rodents. Lots of things work in rodents. The challenge is, can we translate this to a human? Can we do a large animal model? And this is why we then decided to recapitulate our work in a goat. And I discussed earlier why goat. It's an upright animal. Its cervical spine is roughly the same dimensions as a human spine in terms of the disc volume and disc end plate structure and size. And for a variety of ethical and other reasons, it's not, in my opinion, appropriate to go from a rat to a primate. And there's a bunch of issues of primate research I'm not going to get into now. We thought the goat was a good next step. So we recapitulated the study in the goat, and I'm going to zoom through this to get to the interesting stuff. This is the goat neck. I've done a discectomy on the left and a partial corpectomy. These are human instruments. We put in catheter pins and extracted the disc. Then we implant our tissue engineered disc. And this has been grown in vitro, as were the rat discs, to mature it. We take off the compression. Now, this part, you're going to scratch your head, but let's bear with me as I explain it. And then we put a plate on it. Like, hold on, Harvey. Why are you putting a plate on your disc replacement? Well, because this was the first study. And you need to do small iterative steps. So my thought process was, will this integrate in the goat? Well, if we put it in and plate it, which is the most advantageous environment for integration, if we can't achieve integration here, we need to go back to the drawing board. So we didn't want to skip this step. The first step was to show in an artificially advantageous environment, we can get integration. The next step, which we've done and published, was taking the plate off with the second surgery and remobilizing the disc. And currently, we haven't published yet, but we're now moving forward with no implant, without a plate. And so this is a post-op goat, post-op day 0. I'm happy to report I've had 0 patient complaints with this surgery. Unfortunately, they don't fill out patient satisfaction surveys on Google, but they do great. This is literally hours after the surgery, up walking around, eating hay and doing great. And so how does it do? Well, pre-implantation is the top left. This is at 1 month. It integrates, again, like the rat, functional integration, collagen deposition from the vertebral body to the end plate analog. And MRI findings at 2 months, it's integrated and functioning like a disc. Now, this is the MRI. What I would argue is a T2 marker for function. I'm going to show you the proof of it, though. We then explanted these segments and put them on the instrom. And again, just like in the rat, the far right's pre-implantation. And with time in implantation, by 2 months, it was exceeding the design criteria of the native disc. So it matured post-implantation. And again, this is the toe modulus for those of you who are in the stress strain curves, showing how it functionally matures after integration. And again, then we have the biochemistry, histology, biomechanics, MRI findings. And even with ripping these apart under failure, even at 2 months, roughly 8 weeks, we still had a 10 cell failure that was within about 50% of native. And that's only at 2 months. And so we've shown then with long-term in vivo studies in a large animal model that we could perform a discectomy, replace the disc with a disc that we've grown. It functionally integrates. And by every metric that I can think of yet, it functions like a disc, as the biomechanics of a disc, biochemistry of a disc, and histology of a disc, and the MRI findings of a disc. So currently, we're now on some other things we haven't published yet, so I'll just allude to them. But basically, we're now doing longer-term studies with the goat, longer-term studies with not needing provisional fixation. We're doing aims of the study now comparing this to the gold standard, which I would argue, which is a mechanical disc arthroplasty. So we're doing some surgery with goats with mechanical disc replacements, and then we're going to use a human disc replacement. I won't mention the brand, and then compare it to our tissue engineered disc replacement. And then ultimately, these were made with banked cells. Ultimately, it would be to make a disc replacement that is made from the goat's own autologous stem cells. The argument then being, if you go to a human trial, you could come in, you have a degenerated disc, bone marrow aspirate, spin down the cells, get the cells we want, expand them, grow the disc with your cells, and then implant it. Now, there's some other ideas too. You need to do that, but that's beyond the scope of this presentation. So an offshoot of this, which is really exciting, I think, is what have we learned about this? We've learned you can do tissue engineering on the disc, which I wasn't so sure about up until about 15 years ago. So with a disc herniation, we know the nucleus pulposus ruptures through the annulus fibrosus. And we know that causes a downstream cascade. And I'm going to see how much time we have left. Submit to you.
You're fine. You're fine.
Perfect. I would submit to you that this annular injury is much more profound than some of us realize. And there's a lot more we need to do earlier in this disease process so that we don't lead to the stage of individuals needing fusions or mechanical or tissue disc replacements. And so right now we have a disc herniation. This is, we know from the sport trial and others, everybody gets non-operative treatment. For the subset that doesn't get better, you get surgery. But currently, we do not yet have a way to repair the annulus fibrosis in a way that restores the tension, restores the loss of the pressurization of the disc, and restores its biomechanical integrity. And I'm going to show you some data that explains why that's a real problem for the disease process of a disc injury. So one of our postdoctoral students, Dr. Bonavie, and I'll have his picture later, he was interested in this. So we, again, borrowed from Dr. Ron and Dr. Masuda. We did the needle puncture model of the lumbar spine. And you can look, and so this is the left slide. When you do the needle injury, as early as 2 weeks, you start seeing aberrant remodeling of the disc. And if I look to the right, these were disc motion segments that we did tissue culture on. The mere puncture injury leads to apoptosis and cell death in the disc. And you can see with the DAPI staining, the loss of organization of the cells. With the caspase staining, you can see the increased apoptosis. And you can see it's just a disaster. And this is just a needle injury, causes massive death of the disc. And another study that he did, and this is almost, I could do an hour on just this paper, that when you take cells, we took our AF analog, which is the nanospun PCO, and we grew AF cells on it. And we then put it under strain, just like your AF cells are. And we took that strain and we released it. And if you look to the right, can you see my arrow, Dr. Geyer, on the screen?
Yeah, we can see.
So if you look on the right, look what happens at the percentage of at the apoptotic cells. When you have a strain of 9% and drop it to 4%, the cells die. And you see that over here. And then when you have something at 4% strain and increase at 9%, they don't die. So these cells have mechanosensing to their environment. And I can't get too much into the weeds on it. It's a huge topic. But basically, as you rapidly detension the AF cells on a matrix, they undergo apoptosis and they start to express SMA, smooth muscle actin, to become almost like a myofibroblast, and it leads to this degenerative cascade in the disc. And it's beyond the scope of this. But you look on the bottom right, for those of you interested, we also showed there's some therapeutic modalities that attenuate the apoptosis, but that's something to look into later. But we've published it; the data's there. So AF injuries are a real problem. And currently, we don't have a way to fix it. So this is a literature search I did a year and a half or so ago. Actually, Dr. Pareto did it. Anna, she's was our PhD student. She's now Dr. Pareto. And basically, the state of the art with disc repair. And there's not a lot that's been done. There's very little in a large animal model, and there's nothing to date that addresses the inflammation. So how can you fix an AF injury? And what I will show you is this. One of our collaborators, a bunch of them, Dr. George Dodge, has what are called mechanoactivated microcapsules. And this is basically a way in which PLGA spheres can be created. And they have different shell thicknesses based on how you do the annealing and the osmolality. And we can put protein therapeutics into these capsules. The key thing then is when we do that, we were able to tune them for the degradation rate, tune them for what forces will cause them to rupture based off the thickness diameter through the osmotic annealing, to then deliver active biologics under certain force conditions, and also deliver therapeutics such as IL-1 beta or anakinra, which in anakinra is a very powerful IL-1 receptor antagonist, which would, in theory, block inflammation and downstream effects. And so we also showed the effects of this then when we did some studies with MMP3 and LCN2, and just basically show that these things have anti-inflammatory effects on the disc cells. And basically, anakinra delivery attenuates the upregulation of the catabolic genes. And this was done as in vitro study with the spheres. We ruptured them and then showed the effect with PCR. So the theory then was, if we could deliver these drugs to the disc and repair the AF, we could have a patch that retensions the AF, annulus fibrosis, and then with repetitive stress strain delivers therapeutic modalities to stop this degenerative cascade of a unrepaired annular defect. And so these MAMCs were then placed within scaffoldings, which we call the TARP, the tension activated repair patch. And if I have any students or residents, one thing I've learned with the grant funding, you've got to come up with good acronyms. So we have the TARP. And based on the melt stamp geometry of the sigma, the size of these rhomboids, it affects mechanical properties at which they release their contents. And so we did a bunch of in vitro studying. There's the TARP under dynamic tension loading. And we show with loading cycles the percentage of contents released based off the stamp geometry. So we could tune these things to do what we want. And on the right here, 0 cycles versus 3,600 cycles, just showing that the microcapsules release their contents under biomechanical strain. So this was published about 2 months ago in Science, where we did this patch on annular injuries. And we were very fortunate. We got the cover of Science, which is pretty cool. We did an AF injury in the goat, and I'm going to show you, we repaired it. The patch integrated, we healed the annulus, and it stopped the degenerative cascade. That's the next few slides. So there's different annular injury models. What we did was a cruciate cut and then a stab with a full thickness puncture. And so this was, we did in the goat cervical spine. Again, I'm a little bit wedded to that model at this point. So here's our injury on the bottom left. We have our cruciate cut, and you see the outlines of the cruciate cut with the dots we put on, and then the annular stab is in that dotted circle. We then did one of two things. I sutured down either an empty scaffolding or a tarp that had anakinra designed to be delivered. And the suture is just like you repair, well, I repair a bad durotomy. I know nobody else gets durotomies but me, but he's a 6-0 Gore-Tex and just sewed it down. So here's a picture of it. It's basically an inside out suture through the annular defect, bring the double arms of the Gore-Tex out. We walk the patch down, and then we suture it. And again, 0 patient complaints. This is the goat post-op hour, about 5. They love their hay. And so this fellow is doing great after the surgery. And what are the outcomes? Well, again, same thing, biochemistry, MRI, histology, biomechanics. That's, you need to do that. And so what we showed was that these scaffolds integrated by 4 weeks. So everyone says the disc is avascular. I submit to you, just like we show with the DAPS, these scaffoldings integrated to the annulus. And again, we see here the matrix staining, we see matrix deposition. On the right, you can see the MAMC outlines in the histology. And with robust deposition of matrix throughout the scaffolding, it integrates to the disc. And while we did this, remember, we retensioned the disc because we brought the disc back together. We sutured the annulus to restore its properties. And you remember from the slide, 5 or 6, 15 slides ago with Dr. Bonavie, within 24 hours of an annular stab injury in a rabbit disc, the cells start to undergo apoptosis and aberrant remodeling. So again, T2 maps, injury and control. So you see the injury has a real effect. It was a real injury. And we see the differences in the MP region. And then we look at the injury and then the scaffolding. Even the empty scaffolding, the mere act of just restoring the tension to the annulus fibrosus so it's not flapping in the wind, helped to mitigate the injury cascade. When we added anakinra, you see a robust response to the MP and the AF compared to the injury. Now, histology. So again, we have the control on the left, injury on the top right, and then we show the E scaffolding, which is the empty scaffolding, just fixing the tension, and then fixing the tension and delivering anakinra. And you can clearly see the differences in the extracellular matrix retention. You look at the top right injury, you can almost see through it now. It's lost so much proteoglycan. And that proteoglycan, we said in the beginning of the talk, is a shock absorber of the disc. It's what helps you walk on water. With the anakinra scaffolding, it's retained relative to the injury. And here on the baseline at 1 is native control. You see with the injury on the far left, the drop for control. And on the right with the anakinra loaded scaffolding, you see we maintain the quantitative measurement of the Austrian blue intensity. It's not just me waving my hands about it, it's measured. So then we look at the collagenous scar. And this was the control on the left, injury, empty scaffolding, and anakinra scaffolding. And you clearly see it integrates. And the infiltration area you see gets better when you add the anakinra. And then we look at the biomechanics. And this is what's really interesting is that now the one thing is the anakinra scaffolding, knee scaffolding, the disc got stiffer, but it mitigated the degenerative cascade. And I'll show you where that is here. You look at the infiltration area here from control to the anakinra and the empty scaffolding versus the injury in terms of the posterior infiltration area. And it's a dramatic effect when you repair the annular injury. And here's what's really interesting is, remember, we did this injury to the front of the disc. The posterior disc is the opposite side of the disc. We don't touch it. It's the only thing the posterior disc knows. It's what it's informed from the changes to its biomechanical structure or the chemical cascade from the anterior injury. And with the anakinra loaded scaffolding, look at the cell density. The posterior annulus, the cells don't die. You maintain the cell density comparable to the control, whereas the injury on the opposite side of the disc, the cells have all died, or most of them. And the E scaffolding attenuated it somewhat, but the anakinra scaffolding really attenuated it. And so this is really showing how, remember, we did an annular cut on the front of the disc and stabbed it, repaired it, and the back of the disc didn't die. And so this shows retention of cell survival in the posterior AF after we repaired an anterior injury. And so what we've shown so far, in addition to our whole tissue engineered disc, I'm really excited about this application. I would posit that perhaps 10, 15 years from now, when someone comes in who's 25 or 35 with a large L5S1 disc and an annular defect, it may be worth fixing the annular defect. And right now, there is one FDA-approved device, but it's more of a plug that blocks it. It's not really repairing the tension of the annulus and forestalling that, what I believe to be the biomechanical cascade. And so we've shown that we're able to get good scar infiltration and integration of our patch, and we're able to mitigate the cell death on the posterior side of the disc and increase the proteoglycan extracellular matrix contents. The one thing which may or may not be good is the disc is stiffer after we put the patch on. What that means, we stay tuned. But we do stiffen the disc somewhat, but we are able to keep it, for lack of a better word, alive and forestall that degenerative cascade. So we're working now on longer in vivo time points. Some of these things, we have some alternative ways to attach this patch besides the 6-0 Gore-Tex suturing that I do. but some of these things I can't speak to yet. It's sort of, we haven't yet published it, and we're also looking at some additional biologic time points. And now in the last remaining minutes, I need to acknowledge a lot of people. And if I leave someone out, it's due to stress and time constraints and not due to any reason. So the top left is the core group. In the center, the arrow, that's Rob Malk. He's my close friend, research mentor. He really took me under his wing when I came to Penn. He leads a huge research effort, not just with disc, but across cartilage, shoulder, pretty much anything musculoskeletal. And this is the group out throwing axes, axe throwing. I decided I wanted to keep my finger, so I didn't go for that. This is Eddie, the one I talked about who did the tensioning study. Sarah as a postdoctoral fellow. She's now a well-funded independent investigator and a leader with ORS. Donhua did a lot of the salt leach foam end plate PCLs. Anna, I talked about, she did the lion's shares of the work for the Annie Kenra and the MAMCs. This is our DAPS team, the tissue engineer disc. That's my big pumpkin head. Dr. Scher, one of my colleagues, he's a real leader in large animal models and research at our vet school at New Bolton. And he been with me shoulder to shoulder through every single goat surgery. This is Beth Ashinsky. She was an MD PhD student with us. She's now an ortho resident in New York, and I'm sure is going to do amazing things, and a tremendous surgeon. This is Dr. Goldbrand, who is here as part of the surgery. This is Anna. She was a PhD student with us who literally staked her thesis to getting this to work for the annular patch. Tremendous job. Also need to recognize Dr. Hilliard, our biomechanics core, and also the MAMC team, and also Mechanotherapeutics now is their company with Dr. Dodge, Lee, and Zlotnick. And last but not least, but quickly, I tell you, when I was a first year med student, I walked into Mike Smith's lab at Penn State Center for NMR, said, do you have any summer student projects? And Mike Smith, Dr. Chris Collins, Tim Mosher is now the chair of radiology at Penn State, and Ching Yan took me under the wings, literally gave me the keys to the lab, which I never left, said, don't break anything. And over the next, I did a Howard Hughes fellowship for a year and then kept going there nights and weekends. I broke everything and they smiled and just put up with it. And the point is, this is back a long time ago. It's so hard to do independent, non-funded research now. And when I was a med student, I didn't realize how much money I cost them. They brought me into the lab, got me interested in research, and just incredibly gracious with their grant funding to just a nobody med student. And just remember this for you out there, faculty, residents, just when med students come and ask, do you have a project from me, think about it, because that project might change the course of their career. My chance meeting with Dr. Smith changed the course of my career. And these are my clinical colleagues at Penn. I do reference Dr. Koss, our division chief, Dr. Dave Casper, Rush Fisher, who's I think in this region where we are, one of our leader, if not the leader in mechanical arthroplasty. He sent me a beautiful clinical slide the other day of a 3-level lumbar disc that he did. Sharif and Vincent Arlet, our leader who recruited me to Penn. And I couldn't do what I do without all their support, because when I go to the lab, I'm in the lab and they really give me protected time because I have all these tremendous colleagues and wonderful surgeons backing up my clinical practice when I'm in the lab. And so on that, if we have time, I'd like to take any questions. And again, can't thank you enough for the opportunity to share some of our work with you.
Well, Harvey, that was terrific. Why don't you share your screen and we'll field any questions. I have lots of questions, but I mean, what an amazing amount of research that you've done, and really incredible. So my first question for you, so when you're showing the disc that you not synthetic, but the disc that you put in the goats, you said you were getting bank cells, is that correct?
Yep. So currently we did some bone marrow harvest on the goats and then expanded the cell lines and froze them down. So we have sort of our own labs banked cells where if I need goat MP cells or goat AF cells or MSMC, whatever cells we need, we have a tissue bank that we've acquired. So we're doing goat to goat cells. So yes, right now we're using cells we harvested from other goats that we've isolated and spun down and frozen.
So Harvey, I know you can't say in terms of timeline. What do you think is a timeline to doing the first in human experimentation? And I assume that you would do the cervical because it's much smaller, much easier to do the lumbar.
Yeah. Again, I think the annular patch may have a quicker pathway, but for the tissue engineered, it's something we need to discuss with the FDA. It's a little bit of a complex approval process. We'll need to get the goats out to at least a year, if not 2 years, and then approach the FDA with our safety data. And the question will be, is that enough to then go forward in a human study with either banked human cells and allograft or autologous human cells, or will there be another step or iteration? That's something I don't want to speculate about inappropriately. It's something we'd have to use the FDA's guidance for. But if I were to speculate, I'm always an optimist. I'd say within 5 years.
That's really exciting. And, it's one of those kind of things that, people have talked about. I remember going to China. This is probably 5, 10 years ago. And one of I thought he was like a crazy scientist, but he was doing cadaver cervical disc replacements. He took out the cadaver spine and he showed a few pictures that looked good, but then his colleagues said, no, they all failed, they all failed. But it's just amazing. And you're really to be congratulated. The other thing that I found so interesting was what you said about the herniated disc in the lumbar spine. And I never thought about that. So just the act of a herniation. And that's why we see so many patients that come back that are ideal candidates for disc replacement. Their disc is totally shot. There's nothing redeemable about those discs. And, I know that they've had some commercial annular repairs out. I mean, that I think would be technically difficult. I've tried to do some of them myself, but, the data you showed is really, really cool. But look, the engineers will figure out a way to put stitches in, I'm sure, and we'll make it go easy.
Now we've got a collaborator. We're working with something that's hopefully, I think it will be a little more facile than 6-0 Gore-Tex sutures and, lots of knots in a tiny spot.
I'm going to ask one of my fellows that's on here, Kaylin. Unmute yourself.
Yes, sir.
All right, here you got Dr. Smith, that has done more research into this than anybody else. So you're just starting your career this coming August. So what do you want to ask him?
That's right. I'd be interested to hear. So I'm working on my next neuroscience presentation for technology and robotics and artificial intelligence and its clinical applications into spine surgery. So I'd be interested to hear, how does artificial intelligence and robotics play a part in this research here?
And I have to caveat, I don't understand much about AI other than what I see on the headlines, but I think particularly for the quantitative analysis, I mean, there's so much, when I show those T2 maps, there's so much data in there that we're glossing over by just doing a bulk sort of regional analysis. And an area with AI where you could have something go in and segment it, reconstruct it 3-dimensionally, and not look just a bulk difference, but a true space and morphometry differences, I think would be incredibly powerful. And for all these data analysis, I think AI is going to just so exceed what we're able to do as individuals with pattern recognition and bulk data analysis that it's just going to truncate. I mean, it's a lot of work to do all these calculations and analyses, and particularly for data that's already in a digital form. I think AI is just going to just rip through it, and they're always showing in other fields like astronomy and things, just look through signal patterns and just find things that we didn't pick up on. In terms of robotics, I think the sky's the limit. Obviously, we've got our hands, it's a small spot. The ability when it comes to that with what our general surgery colleagues and urologists and OB/GYN docs do with the Da Vinci, where you can be at a console and have the robot be an extension of your hands. We're not there yet with how we use robots in spine, but particularly like for this annular patch, for example, to be able to get into the canal, maybe even endoscopically, robotically, and do a robust suturing technique with visualization, it's going to be a game changer. And I'm hopeful. And again, I don't know much about robots beyond, the stuff we all learn, the basic stuff in spine surgery with what we have available. But if we can get to something on the order of what they have in general surgery, to use something where you're at a console with whatever magnification optically you choose to get with your robot, and then with your hands, effect action at a distance at a small scale, that's going to really change things.
Harvey, just an observation from 10,000 feet, because you've shown us just so much great information. But I want to commend you on just the logical, scientific, ethical way that you've developed your research. And I think that's a really good lesson for all of us, young and old. Obviously, you've made this, your lifetime career research, but you've done it in a way that is very defensible because you've built upon your foundation and then added building blocks in a very measured way. So, hopefully, as Dr. Geyer was saying, you'll be able to bring this to good clinical use for our patients. But just very commendable in the way that you've done this. And just one quick question from our chat room. Somebody said, should we stop doing discography? Because you've reiterated again in the small animal model anyway that a needle puncture starts the death cascade for discs. But actually, practically, we haven't seen that a lot in our patients because, as you know, the Dallas discogram scoring system was developed actually before I got to Dallas in the early 90s. So we should have been, the nucleus of a lot of patients coming in with adjacent level disease, because in those days we did them at multiple levels, and just that hasn't happened. So do you think that's a function of the relative size of a human disc versus the small animals? Or is there something else going on?
It could be, and I don't do discography myself. I mean, I refer people for it, so I don't recall the top of my head the size of the needle, but certainly, I mean,
It's a 22
needle,
gauge, Harvey. A
yeah,
22
and so
gauge.
yeah, so an 18 gauge needle and a rabbit is very different from a 22 gauge in a human. So that may be part of it. I know at one point, I think Dr. Carrick, you published a paper that showed there may be some concerns with the asymptomatic control level with discography about maybe a higher rate of herniation. I would say discography is a tool, and sort of we're all just doing the best we can do with what we have right now. So I'm not here to impute discography, but I would say if with whatever, maybe with MRI quantitative mapping, and not just me doing it, but NociMed is doing some great stuff too. If we could find a way to get the results that we believe we get with discography without doing discography, then of course, who wants to put a needle in the disc? But we're limited by doing the best we can with what we have. And discographies, as you noted, Dr. Geyer, has been well studied and it has its uses clinically. So I think it would be inappropriate to say we should stop doing it, but I think it's fair to say it would be nice if we can learn what we have from discography and get to the next step.
Well, Harvey, anecdotally, because of Gene's article, we stopped doing controls. And a lot of that has to do with really, really strict patient selection. So we only do it on those equivocal patients. But Harvey, again, just to reiterate what Dr. Ziller said, you're to be commended on some really incredible research. You definitely are going to make a difference for the future of our patients. And let's see, I'm sorry, I just clicked off here for a second. You're going to make a difference for millions of patients in the future. And, what an amazing career. So we thank you very much for doing this. I know you put a tremendous amount of work, and I have to say this, I've been trying to get you to do this for a long time, but I will tell you, it was worth the wait. And I hope everybody enjoyed it. So
thank you,
again,
sir.
I could give you a round of applause, but I think everybody really enjoyed it. So thank you very much, Harvey.
Thank you, sir.
Everybody
Thanks.
take care. Don't forget to claim your CMEs 1182. Harvey, you take care.
Good
We'll
night.
see you.
Thanks again.
Thank you. You too.